Bismillah ar-Rahman ar-Rahim. Welcome to this new meeting of the Egyptian Society of Nephrology and Transplantation, CME, in our usual date, Wednesday 9 p.m. Welcome everyone. Today we have two great professors well known in the field of hemodialysis from Ain Shams University. Our moderator today is Professor Magdi Sharqawi, Professor of Nephrology and Internal Medicine at Ain Shams University, one of the Afghan committees for dialysis. He is also the leading of Ain Shams annual conference up to its 13th cycle now, which is one of the well-known international and national and Arabic conferences in the fields of dialysis and nephrology. Professor Magdi is our moderator today, and will lead the session, which will be by Professor Hesham al-Sayed, who is the man of hemodialysis in Egypt and Africa, and one of the landmarks of dialysis worldwide. He will speak about uremic toxins and how to deal with regarding hemodialysis modalities. Professor Hesham is the Vice President of Egyptian Society of Nephrology, and I will leave Professor Magdi now to introduce more and more Professor Hesham and give a hint about this important topic, and Professor Hesham to speak about. Please, Professor Magdi.
Assalamu alaikum. Good evening, everyone. Welcome to this evening meeting. I'd like first to thank Professor Yasser for her persistence and his effort to keep this educational CMEs alive. It's my honor to introduce my brother and my friend, Professor Hesham al-Sayed. I think no one in the Middle East, no one in Egypt, no one in Africa doesn't know who is Hesham al-Sayed. He is one of the illuminating figures in dialysis and in hemodialysis research and hemodialysis technology. And I think even worldwide, he's well recognized for his publication in the field of hemodialysis. Today, Professor Hesham will talk about a very important topic. And this topic is keeping changing. Every few years, it's changing, and our understanding of uremic toxins is changing, and it will change the way we deal with this uremic toxin, as we will see in the presentation. Without further delay, I'd like to invite Professor Hesham to start his interesting topic, uremic toxins, updates, and management and in the modalities of hemodialysis. Professor Hesham, go ahead.
Thank you. Good evening, everybody. Wishing you a very good evening, a warm evening, actually, yes. Thank you, Professor Dr. Yasser, my colleagues and my friend, and Professor Dr. Magdi Sharqawi, my colleague and friend, and good evening all for this talk. I will highlight today some of the important new issues in our understanding of the uremic toxins and the modality of therapy, what's new and how we can approach on that. So I keep you updated on that, and we'll start by the agenda today, talking about what's new in uremic toxins, classifications, and examples of some of the uremic toxicity. What's new in home dialysis, which is an emerging opportunity for patients on dialysis, and the outcome, not only on the era of COVID, but on the era of mortality, especially the nocturnal dialysis. And finally, we will have a hemodiafiltration, new researches and the publications in Ain Shams University, and also on the worldwide. So going to the uremic toxin from Van Holder, who saying that UTOX and a variety of uremic toxins have been identified. Although the number of uremic toxins identified in the early of 2000s is around 100, but still building up more and more of the uremic toxins. So in the classic taxonomy, uremic retention compounds are divided into three main categories. These are the basics: A small solid with a very small solid, less than 500 Dalton, and the middle molecules, which expanded to more than up to 15,000, and protein bound uremic toxins. However, protein bound uremic toxins coming from very small solids, unfortunately, it's bound to albumin. So we're having a significant kinetic differences. So it is not the molecular weight or the toxicity, the significant kinetics differences which affect the modality of therapy. If you have 2 or 3 kinetic modeling poles, we will have a difficulty in removal or needing more attention on dialysis. Both urea and creatinine are the surrogates of that, the godfather of uremic biomarkers. However, still their toxicity is still undefined. And finally, the renewed interest in the potential toxic effect of inorganic compounds, including sodium, potassium, water, hydrogen, iron, phosphate, calcium, along with the treatment-related determinants of their removal. So the classic one of the small solid, water-soluble compounds, and the molecular weight with the prototype is urea, is around 60 up to 500, and the protein bound compounds mostly are small molecules but attached to proteins. The prototype like indoxyl sulfate, and the middle molecules more than 500 Dalton, and the prototype is the beta-2 microglobulin. Uremic toxin, what are they? An integrated overview of pathobiology with a connection between the toxic substance and one or more of the pathobiological or clinical features of the uremic syndrome must be firmly demonstrated. So it is changing the panoramic view of the uremic toxins from just the retention molecules. Now we can do a pathobiological correlation between a retention molecule and its effect. Subsequently, recently, the uremic toxin has been classified into more 5 types or even 6 types. However, the main 4 types are type 1 with an accumulation in the body fluids of toxic substances normally produced endogenously by metabolic process, largely as a result of reduced renal excretory capacity, like urea. While type 2, it is an excess endogenous production or impaired degradation, or both, but not because of reduced renal excretory capacity, exactly like parathyroid hormone. And type 3 involves the accumulation of toxic substance in the biological fluids from exogenous sources by virtue of reduced renal excretory capacity. Example, drugs, overdosing, toxins, which could be removed by the kidney, but failing kidney cannot. And type 4, which is the last one, is a deficiency or reduced activity of substances normally produced endogenously as a result of decreased synthesis, enhanced degradation, or biological inhibition. Open the door for all the metabolomics effect of uremia with associated accumulations of many of metabolites. The unsolved problem is the large middle molecules in inflammation and the cardiovascular diseases. Now, it's finally, we all know that the cardiovascular diseases and the plaque rupture and thrombosis is related to many of the uremic toxins. Example, the cytokines, interleukins, tumor necrosis factors, as well advanced glycation in the products, adhesion molecules, and others. So many players in the uremic toxin milieu can induce one organ damage or multiple organ damage. The debate on the protein bound uremic toxin is still present because we are lacking that the gut microbiota is responsible for the productions of the protein bound uremic toxins, for example, the bicresol coming from tryptophan. And this is the uremic toxin has multi-phases in the toxicity, mainly in the cardiovascular, as well in the progression of chronic kidney disease. So retention of such a molecule in the era of chronic kidney disease will increase the progression to end-stage kidney disease, giving an open door for the treatment of microbiota, changing the media and the field in the gut. So the middle molecules in the range of 15,000 to 60,000 that have evidence for involvement in inflammation and cardiovascular disease, now becoming a very recognized uremic toxin, far away from the small solids like urea or creatinine. And this is very big example. If you can see that the molecular size and their biological role, you can find that the molecular weight in kilodalton extending, approaching up to 50,000. Most of them are modulating either the pro-inflammatory cytokines or promote endocellular cell proliferations, angiogenesis, phosphate homeostasis, or components of alternative complement pathway. So it is a multi-organic compound that moderate and manipulate the whole body, not only the heart, the brain, the gut, the neurological as well either. And if you put that on the right panel, you can find that how many folds are higher in patients with chronic kidney disease. Still, we know that there is a lot of unknown in the uremia. So what had been identified is still far away from the metabolic error and retention molecules in patients with chronic kidney disease. So the classification of uremic toxins and their role in kidney failure, recommendation for the update in the classification, beyond the physiochemical characteristics, we have to do their linkage to clinical symptoms and outcomes, and how the dialytic removal pattern of uremic retention solids. So the physiochemical classification, the old one, is unsatisfactory, not adequately address or reflect how current modern hemodialysis technology like adsorption, convection, and diffusion remove toxins. And classification on the basis of its nature toxicity to the organs, that unmet uremic toxin does not adequately reflect the biologic consequences of the toxins. And finally, the classification on the basis of patient's outcome, morbidity, mortality, complications, is still should be identified. So this is, I think this is one of the fine graphs, if you put that in the current classification from Van Holders of the UTOX, when defining the molecular weight alone and the terminology limitation that chemically identified and biologically flowed are broad, overly broad and non-specific, and has suggested update that the solids identification and the quantification analysis in the blood should be possible for the plasma, giving the chance of new biomarkers, not only from the base of the chronic kidney disease assessment, but as well for the dialysis adequacy, and negatively affect conforming with contributing to biological or clinical changes. So what's new in uremic toxins coming from the laboratory as well research from identifying retention solids? We have to identify carefully which solids had been identified and its correlation to the disease. Subsequently, we can find a way to remove. Another example here, if you have a uremic toxins on the left panel, can even damage the kidney, meaning that patients with chronic kidney disease, we all know that some of them have higher progression to chronic kidney disease and end-stage kidney disease, and some of them are slower in progression. It's a multifactorial, we understand, controlling of the metabolic error, diabetes, hypertension, hyperuricemia, fluid balance, nephrotoxicity, and etc. But even uremic toxins itself can do more damage and more CKD progression. When you find that to hematological immune system, endocrine, cardiovascular, neurological, and even nutrition and the muscles. So the biochemical and clinical impact of organic retention solids is this very comprehensive literature defining that. Is this new literature meaning that maybe one toxin can induce multiple organ damage, and multiple toxins can induce single organ damage. For example, if you can say cerebrovascular, we have one toxin or two toxins or three toxins affecting the neuropathy, as well for the cardiovascular. So it's a correlation between either one toxin can induce multiple damage or group of toxins can induce single organ damage. According to the number of affected systems in experimental studies, the highest rank of uremic toxins that induce organ damage is both the protein bound and the middle molecules. So keeping in mind that we still are defining that KT over V is a dialysis adequacy. I'm against that at all, because the rank of the toxicity of uremic toxins in the literature is very low regarding the small solids. So we have to define a new way of dialysis, prescription, monitoring, as well adequacy. So the highest toxicity evidence score coming from beta-2 microglobulin, bichloride sulfate, asymmetric dimethyl sulfate, as well some of the advanced glycation end product cytokines, endothelin as well. So we will come to later some example of their toxicity of this example of the middle molecule. So the recommendation, meaning that the group suggested that pathophysiological effect of each uremic toxins, like inflammation, cardiovascular, and solid origin, intestinal generation should be stated wherever available, and they're suggesting focusing on a limited number of key body system effects that are most prominent in uremia, such as cardiovascular damage, susceptibility to infection, neurological, as pathophysiological classification. So the new classification scheme must link uremic solids to traditional clinical outcomes and quality of life measures. We usually miss the quality of life in patients with dialysis, including pruritus, restless leg syndrome, and the recovery time after dialysis. The three-steps approach for a better hemodialysis outcomes is identification of uremic toxins, representative biomarkers for different classes of uremic retention solids, correlation of such uremic toxins to clinical symptoms and outcomes, and finally, how to facilitate the personalized and to target dialysis prescription to improve quality of life, morbidity, and mortality. Treatment to prevent damage from uremic toxins, more effective removal of uremic toxin by dialysis, as protein-bound uremic toxin cannot be eliminated using current dialysis strategy. It's very big, more than any of the dialysis templates. Or we can use pharmacological agents to interfere with the production, absorption of the colon-driving solids. The impact of uremic toxins on cerebrovascular and cognitive disorders toxins coming from the vascular dysfunction and its action on the brain structure. For the vascular dysfunction, endothelium, always you find endothelial damage anywhere in any organs, atherosclerosis, hypercoagulability, vascular calcification, risk of thrombosis, hypertension. So all of them are equally in many organs, and the actions on brain structure itself by infiltration of monocytes, endothelial dysfunction, pro-inflammatory cytokines, or oxidative stress. When looking to the heart and the cardiopulmonary risk, you can find also many of the uremic toxins can induce cardiomyopathy, ischemia, hypertrophy, maybe due to volume fluctuations or electrical dysfunction, electrolyte shift, or direct effect from a specific uremic toxin. The scheme of uremic toxins affecting different regulatory steps of cardiovascular calcification. Either we have minerals abnormalities or inflammatory cascades, oxidative stress, and transcription factor with increasing osteochondritic differentiation genes, apoptosis, senescence of cells, premature aging, and finally, you can find mineralization of the endothelial cells. So uremic toxins are an alarming danger concerning the cardiovascular system, including the expression of pro-inflammatory cytokines, adhesion molecules, prothrombotic factors, increasing impermeability, all of that affecting the inner layer of an endothelium with transforming of the muscular smooth muscle cells of the vessels, performing that and transferring that to bone-forming cells, and finally, calcification and death. So the crosstalk between heart and the kidney contribution of uremic toxins, either from the metabolic errors, inflammatory errors, increasing in the hypertrophic profibrotic tensions on that, including all of that in one kind of aggressive behavior inducing cardiac injury. The problem nowadays is no way to remove the protein-bound uremic toxin, and subsequently dialysis is not efficient. If you look to the protein-bound uremic toxins, and example of that, the endoxyl sulfate mediated cardiorenal syndrome, it's an organ fibrosis to the kidney with progression of CKD, and to the heart as well with heart failure. So increasing endoxyl sulfate giving a key point how we can change the nature of the colon to decrease the production rather than increasing their clearance by failure kidney. So this is a mechanism of that, and finally increased renal and cardiovascular events from multiple steps, podocytes changes, reduced clot expression, inflammation, gene expression, and finally atherosclerosis and fibrosis. Traditional risk factor as well, if the inpatient with diabetes and long-standing hypertension, when going to end-stage kidney disease, the problem is magnifying and increasing the probability of death from the cardiovascular disorders. We have been published, me with Professor Dr. Mbd and my colleagues, that endotoxins retention in patients on dialysis, meaning that has a very high probability of cardiovascular disorders. And this endotoxemia carried a risk for cardiovascular disease with high specific C-reactive protein positively correlated with endotoxemia and atrial fibrillation. And the endotoxin coming from the gut and related as well to uremic toxins with inflammation. It's well known that human necrosis factor facilitates endotoxin transfer. And this endotoxin transfer either from in between cells due to impaired tight junction or intracellular transfer. Subsequently, there is endotoxemia from the gut leak. So toxicity, retention molecules, accurate classification is difficult. Their potential toxicity remains to be proven with their chemical structure and composition. Giving the light to a novel approach is needed to identify and explain their disease correlation. How to decrease their concentration? Prevent accumulation of uremic toxins. Dialysis is the last step. We can change that by dietary modification, reducing generation in the gut. Importantly, preservation of the residual kidney function, even if it's 5 estimated GFR, 5 milliliters per minute. It's good to remove the protein-bound toxin. Additional environmental factors affecting uremic toxins. Example of that, the phosphate. Phosphate alone is not toxic as much as it's associated with other comorbid conditions like hypercalcemia, deficiency of chloride, inflammation, changing the mono to diphosphate. Acidosis has the same. So inflammation and acidosis, deficiency of chloride makes phosphate more toxic. The asymmetric dimethyl arginine, one of the very famous uremic toxins, because it has a very potent inhibitor of nitric oxide synthase. Subsequently, lower nitric oxide in the vessel, meaning that more platelet aggregation, less vasodilatation, smooth muscle cell proliferation, monocyte adhesions, and else. So this is one of the examples of how one toxin can induce vascular injury. The second example is the beta-2 microglobulin. Interestingly, beta-2 microglobulin in pre-dialysis level does not change too much between low flux and high flux. However, while patients with retained beta-2 microglobulin on low flux dialysis has higher percent of more deposition in the joints. It is simply that high flux meaning not only removing beta-2 microglobulin, but removing additional cytokines that aggravate the beta-2 microglobulin, changing their structure and changing the microenvironment, modification, glycation. And so all of them promote inflammatory osteolysis. Another example of uremic toxin is trimethylamine oxide. It's known that it can induce thrombosis, atherosclerosis, stroke, myocardial infarction. And one of the recent considered very toxic uremic solids is the free light chain. And we have to prospect that free light chain should be removed during our dialysis strategy. Free light chain either can induce light chain deposition disease, but mostly it's retained in patients with uremia due to the lower excretion. Subsequently, free light chain, even in patients not in myeloma, for example, or plasmapheresis, has a very pro-inflammatory cascade with increasing the platelet-derived growth factors, increasing all of that, making the organs are subjected to more toxicity. So there is association between immunoglobulin free light chains with mortality. Among end-stage renal disease, if even in non-dialysis dependent, stages 3 to 5 CKD, if you have a free light chain higher in patient, the mortality is high. And this gives us a good biomarker for the progression and inflammation of patients not even on dialysis, not only in patients in myeloma. FG acid 23, we all know that fibroblast growth factor 23 is a phosphatotic hormone, mostly secreted by osteocyte and osteoblast, indirectly by reducing calcium level, also inhibits the secretion of parathyroid hormone. Accumulation of FG32 and increased production to counteract the phosphate accumulation, to overcome the resistance, the expression of the clotho, fibroblast growth factor clotho, and decrease renal clearance with degradation of fibroblast growth factor. Fibroblast growth factor, what's come in the bone comes into flesh. So it's coming from the bone and induce cardiovascular event, left ventricular hypertrophy, and vascular calcification. How to diagnose uremic toxin? One of the new era is the omics, and the omics, especially the proteomics, identified that uremic toxin has been expanded to include proteins up to 55 to 60 kilodaltons approaching the albumin. So we are doing dialysis for patients ensuring removing that very bigger molecular weight toxins, still we need more. And most of that, of the proteomic analysis, are from the protein-bound toxins, and the middle molecules in the range from 15,000 to 60,000. So currently under identification in omics, biomarkers, cardiovascular events, mortality, CKD, MBD, and the other new biomarkers should be identified. This is my first part, an overview of the uremic toxin. How hemodialysis strategy to ensure removal of uremic toxin. Still, we have the players, the high flux, hemodiafiltration, and expanded hemodialysis. What's wrong with conventional hemodialysis? It's our question. It's non-physiological, short duration, intermittency, protein-bound uremic toxin not removed. Most toxins have multi-compartmental distribution with high rebound, shortly decreased after dialysis, and rebound on the evening. And a high flux membrane are not equal in Stephen coefficient. So you have high flux, but not effective as others. One of the emerging opportunity for dialysis is the home dialysis. And home dialysis has been looking for many of years to improve the quality of life. And most hemodialysis patients have significant unpleasant symptoms during treatment and take hours to recover. However, home dialysis is more flexible and improving the symptoms, improving the post-dialysis fatigue, and improving as well the rebound by more overnight home dialysis. The home dialysis, either to use a basic dialysis machine or a compact one, you can, it's next stage is the very commonest one, is the next stage machine, and you can use either in-center nocturnal dialysis or home nocturnal dialysis, more frequent dialysis, 5 times per week, or more prolonged dialysis, 6 to 8 hours per day in the intermittent way. The extended time nocturnal hemodialysis target of cardiovascular benefits can improve the sleep apnea, coronary calcification, endothelial function, progenitor cells, improving the carbohydrate albumin myocardial stunning. So varying association of that with quality of life has been shown that with more prolonged dialysis, more, especially for patients with nocturnal dialysis, has higher rank of quality and the physical life. You can use a home dialysis, either buttonhole versus step ladder. Buttonhole is the self-cannulation, can be used at home, meaning that injection at the same site of injection by fistula needle or step ladder. However, the study shows that more painful is a step ladder for home dialysis. Buttonhole seems to be more convenient to patients at home dialysis. The water treatment of home dialysis must include the basics of in-center dialysis, but in a compact way. We have softener, carbon filter, RO, and endotoxin filter installed. It is the same way of the in-center, but should be more compact. How to prescribe patient in-center dialysis? It depends on the patient's requirement. Either 5 days per week or every other day. I think every other day is more convenient. What's the difference between every other day and five per week? Every other day, meaning that we don't have a long days in between dialysis. For example, Saturday, Monday, Wednesday, not to wait to Saturday. Do this session on Friday. So every other day, irrespective of the days of the week. This more convenient way for patients as well to enjoy free dialysis days. The candidates for home hemodialysis should be physically and mentally good, should be motivated and willing to learn the technique, should wish to continue to work or continue schooling, who have failed peritoneal dialysis and wish to continue therapy at home, and women who are pregnant or planning to conceive. Patients with the following medical conditions can improve: sleep apnea syndrome, persistent hyperphosphatemia, heart failure, refractory volume overload, difficult to control hypertension, or symptomatic hypertension, cramps, or nausea on conventional short session of dialysis, inadequate control of uremic symptoms on conventional hemodialysis, and excessive recovery time after conventional hemodialysis. So this is basically maybe benefits of the patient to receive home dialysis. While contraindications are unstable medical conditions like uncontrolled arrhythmia, seizures, suitable vascular access, unstable behavior problems, contraindication to anticoagulation, conditions that may cause abrupt loss of consciousness, and severely visual impaired or blindness. So all are contraindicated. So not all high flux membranes are equal in performance. I think this is, for me, is an important graph because it's the roadmap of the dialysis strategy. On the left panel, you have the molecular weight, and on the right panel, it's the correlation of the toxin diameter. So the toxin diameter determines which can pass through the pores of the dialysis membranes. And subsequently, if you increase the pores of the dialysis membrane, you have more albumin leak. So we have to compromise between both of them. We published the seeding coefficient difference in interleukin 1 receptor reduction ratio in high flux dialysis. We can find that there is a difference in between high flux and the reduction ratio. So it depends on the molecular, yes, but also depends on the porosity of the membrane and the seeding coefficient. If you look to this very big graph, it is in vitro studies between different dialyzers and dialysis membranes. On the right panel, you can find that the kappa and lambda interleukin 6 removal with different dialysis membrane. Sometimes you can find that it is 0 or approaching 3.5, and sometimes you can find it's high. So it depends on the dialysis membrane. And if you are dealing with patients with COVID-19, you have to ensure that interleukin 6 are appropriately and extensively removed by both longer dialysis session and higher membrane porosity. So not all high flux dialysis membrane are equal and could be used in the inflammatory cascades. So high flux has different seeding coefficient, while medium cutoff and protein leaking and high cutoff dialysis membrane has higher albumin loss. So it is compromised between what to remove and what to retain, in particularly the albumin. So novel insight into uremic toxicity over the last decades suggests that progressive and cumulative retention of products in the middle molecule weight range up to 45 and even 50,000 might subsequently contribute to enhanced cardiovascular morbidity. Question: Why? We didn't find in the literature much more differences between different therapeutic challenges, because much of the damage to the vascular system might be already been established at the moment the patient starts on renal replacement therapy, taking care of CKD, and this is groups of uremic toxin. To this value is removed by the kidney, but here is metabolized by other systems. The albumin hemostasis in healthy individual and end-stage kidney disease is different. So albumin is inflammation related, mainly in patients with CKD, and the liver support up to 10 grams per day. If you have an inflammation, you touch the liver production or increasing its degradation. Albumin loss in the literature may reach even more than 20 to 30 grams per week, even with peritoneal dialysis or in hemodialysis. Part of them related to clearance from the dialyzer, and part of them due to adsorption into the dialysis membrane. Why we need some albumin loss in dialysis? Because you remove the bad albumin, the glycosylated albumin, and induce renewal of the liver to produce more albumin. This state is very important. The albumin is subjected to irreversible post-transitional modification, oxidation, glycosylation. So a stimulation of increased hepatic senses of functional unmodified albumin is one of the factors underlying the development and use of high-performance protein-leaking membrane in Japan to remove the bad and to produce the new one. Hemodiafiltration is my favorite. You can double toxins removed by the same dialysis membranes. You can use either pre-dilution or post-dilutional way. We discussed that in more details in last session, but increasing the convection volume will increase the albumin loss. Again, it is not bad thing to remove albumin because you remove the bad one. Even if you are using very intensified dialysis, most of the vitamins required are equally to the hemodialysis. So no fear of that increasing. In this literature, some of the vitamin C may be required if you intensify the dialysis. Reappraisal of hemodiafiltration for uremic complication. It's recently published last 2 months that complex interplay between uremic toxin, fluid overload, and organ dysfunction in patients with kidney failure as compared with hemodialysis. Hemodiafiltration lowers middle molecule weight uremic toxin more effectively than high flux dialysis. In Japan, they induce pre-dilution online hemodiafiltration and increasing the expanded the uremic toxin needed to be removed, kappa and lambda light chains, and increasing in the use over the years. And in the Japanese data system registry, for this one from the 2009, increasing abruptly the use of hemodiafiltration, online hemodiafiltration. The prevalence is changing in the Middle East and Europe, considered to be one of the biggest areas for hemodiafiltration. And again, it's increasing in number. The EMEA, Europe, and the Middle East area increasing in this particular for hemodiafiltration, for the online hemodiafiltration over years. With increasing percent of the convection volume, it is the target, not doing only hemodiafiltration. What is the target substitution volume should be achieved? And optimal convection volume should be achieved to have the success and the benefit of hemodiafiltration. Even in Europe and the Middle East, a little can reach the 23 liter in post-dilution. due to multifactorial effects. Clinical effect of hemodiafiltration is a lot. Dialysis-related amyloidosis, hypotension, intravenous hypotension, improvement of anemia, quality of life, restless leg syndrome, inflammation, either observational study, depending on the convection volume achieved, and randomized controlled trial. So FDG-FP23, as mentioned before, is 32 kilodalton and could be removed efficiently by online hemodiafiltration. So the performance is changing if you are using the same dialyzer. If you are doing hemodiafiltration, for example, free light chain, you can achieve higher clearance value and slightly albumin loss. What in the recent research in Ain Shams University is a potential benefit of using bigger surface area and wider sieving coefficient of the dialysis membrane. Higher sieving coefficient giving a wider range of uremic toxin included. Lower albumin loss than in medium cutoff. Bigger surface area with higher clearance value, suitable for hemodiafiltration, more consistent in performance by viable dialysis membrane. Hemodiafiltration can double the molecular weight removal than in high flux dialysis. So large dialyzer surface area and KOF seems to be logic. And if you are seeing here different sieving coefficients, you have to choose the larger one with the high sieving coefficient. Our results for the 2.6 high flux, the provisional results from our data is you can expand the uranic toxin removed from high flux to hemodiafiltration. You can include kappa, light chain, alpha microglobulin, lambda, interleukin 6, and procalcitonin. So we can improve that by increasing the surface area and increasing the sieving coefficient. While albumin loss hourly, the first hour is the highest albumin loss, around 1 gram in the spent dilate, followed by second and third hours and fourth hour. So the total albumin loss in our 25 patients on this trial literature is 2.15 grams, which is accepted below 3 grams. And the transmembrane pressure is accepted as below 300 millimeter mercury by the end of the dialysis. We can achieve higher beta-2 microglobulin with hemodiafiltration. We can remove tumor necrosis factor and asymmetric dimethyl arginine. All these studies are done in Ain Shams University, overviewing the hemodiafiltration effect. So this is the uremic toxin could be removed and comparing high flux by hemodiafiltration. Also with Dr. Magdi Sharawi, we did a very nice, I think it's one of the very nice papers we published, is that the epigenetic changes and DNA methylation that have been improved with hemodiafiltration. Interestingly, it is related as well to convection volume. So successful post-dilution or pre-dilution hemodiafiltration should be met with improved in mortality from the dust and the other. You can see that there's variable substitution volume, so we cannot consider hemodiafiltration as a universal success in all countries. Even in the Gulf, differences between countries like Bahrain, Dubai, United Arab, Oman, Kuwait, Saudi Arabia, Qatar, and still in their data, there is little who can achieve more than 20 liters in the post-dilution way. So adequate prescription of high volume online hemodiafiltration is surely should be identified for each session or per week. And large meta-analysis on convection therapy has been published in the last 2 years, taken together that these studies support the conclusion that high volume post-dilution online is associated with improved overall access, and the recommendation to obtain high volume post-dilutional should be toward vascular access and toward convection volume replacement, with the recommendation the maximum possible. Although above 25 liters in post-dilutional is the same result, so we can have around 25 liters per session in post-dilutional way or 50 liters in pre-dilutional way, we can achieve the that. A lot of studies improving of the cardiovascular diseases with hemodiafiltration, cardiac and non-cardiac, infection-related sudden death, and other causes. And the most important finding in all literature is the cardiovascular disease improvement in patients with hemodiafiltration. It's very difficult to remove the protein bound by any techniques up till now, and still awaiting a magic solution of bioartificial kidney. So, to my colleagues and friends and professors, the uranic toxins identified are still in need for both quantification and their biological effects. In the milieu of uremia, the renal replacement therapy strategies should be pointed toward individualization of the therapy with an optimum removal of uremic toxin using bigger surface area from data. Our research and the more dialysis style may improve the hemodiafiltration convection volume with less membrane damage. And thank you very much.
Thank you very much, Professor Hesham. As usual, an excellent illustration of uremic toxins and its effect, how it is produced, the ways to remove it and the ways to avoid it. And you illustrated clearly that it's not just toxins to the body, but it affects the cardiovascular system, the GI system, and even the progression of chronic kidney disease. Exactly. And the residual kidney function. Exactly. It's very important to be mentioned, and it's very important to be discussed. I think we have a lot of questions. I have seen a question now from my dear friend, again, Dr. Khalid Abu Zaid. Khalid Abu Zaid is one of my colleagues. We miss him in Egypt. He is working in Saudi Arabia, in Jeddah. He's asking you, Professor Hesham, what is the best modality of dialysis for patients with ischemic heart disease, recurrent attacks of resistant refractory angina in an inappropriate patient? This is the first question. I will leave you to ask to answer, and then I'll get to the second question from Dr. Khalid. Dr. Hesham.
Yes, it's a good question, and this is completely individualization. One of them is, first, we have to find a way to improve the cardiovascular circulatory error, because dialysis decreases the coronary blood flow by 30%, and it's called myocardial stunning. And so if you have such that, you have to improve the dialysis prescription. If you allow me just for a second to put my laptop power.
Okay, during this time, I think, yes, there is...
Yes,
oh, he's back, okay.
And second one is to improve the intradialytic hypotension. By improving that, I think one of the best approach, controlling the anemia, controlling the electrolyte imbalance, controlling the coronary blood flow, and doing stable patients in hemodiafiltration, either post-dilution or pre-dilutional way.
Yes, it is a holistic approach. It's not just one approach. It's not just dialysis. You have to correct other factors. The second question also from Dr. Khalid, is a plasmapheresis as a procedure reduce the uremic toxins?
Plasmapheresis is not a prescription for uremia, because you remove at all. You remove immunoglobulin, you remove all of them. plasmapheresis cutoff is 2 million, very big molecule. We are dealing about below 50,000 or 50 kilodalton. So plasmapheresis will remove not only uremic toxin, will remove immunoglobulin, which is essential for the body. So plasmapheresis is not a way of therapy for uremia, unless it's related to thrombotic microangiopathy or other disorders. We can alternate plasmapheresis with hemodialysis as we do in Shams University.
You also commented on what you have said is that home dialysis 4 hours for 3 times per week is not effective and it shouldn't be prescribed. Do you agree in this opinion?
Home dialysis, you have plenty of solutions. We have here as well in Egypt, our experience is that. I think if you do home dialysis every other day, not 3 times per week, I will stress on that. We will not go to every or 3 times per week, because you will have a long days in between dialysis, the weekend free dialysis. So if you are doing 3 times per week, you have to check to do every other day. Number 1. Number 2, can build up the hours you need according to personalization. You may not need more for hours. You may need 6 hours according, if you have hyperphosphatemia or uremic manifestation or volume overload, you have to extend the hours.
So would you advise nocturnal hemodialysis for home patients or day hemodialysis?
Most of patients, if they are not working and stable and not on uremic state, can do daily day use hemodialysis. If they are working, like the Japanese, and the patients needing to go to school or to job early morning and needs more dialysis time, I advise you can do it on nocturnal basis.
So what about protein prescription in intensified dialysis? If the patient is doing 5 sessions per week, will you intensify or will you increase protein intake for him?
I will intensify even if the patient is doing thrice per week.
Okay.
Not 5 per week. Protein is recommended for patients on dialysis, and you know that we discussed that a lot, that never to restrict protein in patient on dialysis.
So I also have a question about HDF and its role in adynamic bone disease. And let me widen the question. What is the relation between HDF and MBD?
It's not related directly to adynamic bone disease. There is a common mistake that parathyroid hormone is only 9,000 in molecular weight and could be removed by dialysis. However, it's a very dynamic gland. Once is the drop of the PTH, there is excess production. The only one that suppresses the PTH during dialysis is very high calcium. So in dialysis. So there is no way, if you are using the ultra pure dialysate water and you are using the dialysis prescription, right, you are giving the right calcium dialysate, you will not have a dynamic bone disease. Surely you don't have aluminum. We don't see aluminum years ago.
So let me ask you a question about if you are going to start HDF, would you start it after many years of hemodialysis or would you start from the beginning? Let me ask you this question in another way. Would HDF now correct the morbidities that happened during the few years of hemodialysis before?
It's a very good and very, you have a very intelligent question. You touch a very hot point. Who will have success and benefits of hemodiafiltration? Is the very long vintage on dialysis, like 5 years, 10 years, as previously described, or from the initiating dialysis, you start hemodiafiltration. What has been deposited, you cannot remove. If you have, for example, carpal tunnel syndrome, nothing will remove. You have to do surgery. So, to my opinion, I should offer hemodiafiltration to any dialysis patient, if even they have a residual kidney function, because it's more stable hemodynamic and the residual kidney function potentially will be stable. So to my side, it has the financial, logistics, all are in the same way. I can go to hemodiafiltration for patients even who are starting dialysis.
One last question for, about the relation of HDF to pruritus.
Yes, there is a study comparing the pruritus effect of hemodiafiltration and its difference between medium cutoff. Both of them improved, but not related to a specific toxin removal. That's why in my first talk, part of the talk is we are missing to identify which toxin related to pruritus, for example.
Okay.
And then a biomarker to remove.
Let us listen to the professors that are present with us, Dr. Said Khamis, Dr. Tariq Tantawi, Dr. Bahazid. If they want to comment, I'll start by Dr. Tariq. Would you like to comment? If you can.
Hello, sir. Good evening. Really, it is an updated lectures. A lot of benefits. We got it from Professor Hesham said today, and a good night. As regard the HDF, I am with you, Professor Hesham. I would like even to initiate for all if it's possible. And I think this is the right way for better clearance and better survival and less morbidity with this diagram.
Thank you, Professor Tariq. As usual, you have the deep experiences and the shortest comment, but in the good.
Thank you.
Professor Said.
Good evening, Professor Mbd, Professor Hesham, Professor Tara, and all the audience. Thank you, Professor Hesham, for this elegant presentation as usual. If you allow me, I have 3 short questions. Number 1, as you know, usually our patient ask us in the dialysis unit to increase the ultrafiltration, aiming to remove more toxins. And our answer, no, it will not remove toxins. My question to you, the more ultrafiltration between brackets within the limit, the normal the proper limit, can remove more toxin, or I mean in another way, help in removing to some extent uremic toxins? That's number 1. Number 2, what about the research in the area of the protein-bound uremic toxins? I mean the splitter or the splitting. It is progressing or not? And the third and last question regarding the dream of selectivity in removing uremic toxins. I mean to remove the detrimental or the bad one and leave the good one. Namely, for example, I can remove the pro-inflammatory and leave the anti-inflammatory cytokine, for example, apart from the molecular weight size. I mean in another meaning, like the electric discharge on the surface of the molecules or something like that. Thank you, Professor Hesham.
Thank you, Professor Said. Again, it's one coming, 3 questions coming from very, very intelligent, with hard experiences, very long experience, Professor Said Khamis in the field of dialysis. I will start answering my first question, but I will start by the third question, because I really need to rethink about the first one, because I missed that. The third one, dialysis is blind. Stop. So you cannot discriminate between which is removed unless it's passed through the pores. What's next will be probably selectivity, but up till now, no. Your first question was, I missed. Please just give me the first question.
Can have any role in removal of the uremic toxins? I mean removal of water.
Yes, yes. You mean that if I remove much water, much fluid, it's increased in the clearance? The answer is yes, because the calculation of the clearance of any dialysis membrane depending on the diffusion and the convection.
Yeah.
And if you are removing much of the fluid, you remove much, and it's sometimes linear, for example, for the beta-2 microglobulin. But this is the basic concept of convection therapy in hemodiafiltration. But if you are using low flux, what the patient will get benefit from higher fluid removal? Nothing. If you are using high flux dialysis, it's already internal hemodiafiltration, and you substitution internally about 6 to 8 liters. So the patient asking is intelligent to some extent and giving the key for the hemodiafiltration rule. For your second question, for the protein-bound uremic toxin, yeah, I fully agree that we need more innovation in this field or displacer. There's some research on that, but it's very little research on giving the patient pre-dialysis some of the displacers that can attach it to the albumin more affinity than the protein-bound toxins and giving that free. By the way, protein-bound uremic toxin, the very small solids. It's like bigger than urea. And if you displace some of the albumin, it should be removed easily. And it is normally removed by the organic amine transporters of the renal tubules. So this laser is giving some insight, but very few literature on this field.
Okay, thank you, dear Prof. Thank you so much.
Thank you.
Professor Baha, Zaid, if you want to comment.
Professor Sharawi, Professor Hesham, thank you so much for a wonderful presentation. And I was lucky enough to, I heard Dr. Hesham before in Dubai about 1 week ago. And today was a nice presentation also. Thank you, Professor Hesham. But I want to ask two questions, please. One about is gender difference in the response to the hemodialysis or hemodiafiltration? Because I remember the hemo study showing a gender difference in favor of women in responding to mortality in patients with using high flux membrane. And another one about cognitive function. If there is any data about uremic toxins and improvement of cognitive function in patients on hemodialysis?
Yes, so thank you, Professor Turba. It's nice to see you this evening. I hope that you have a warm night. Yes, there is some differences if you are talking about the gender, but it's for the KT over V because you are dealing with the just small size. If you go to the hemodiafiltration, no difference between genders in the outcome between both of them, provided that the same rule, the same convection volume, the same frequency, the same duration. So it's not the difference. We can see that the women need more higher KT over V or urea reduction ratio. For the hemo study, to my opinion, since the publication, it's completely biased study and giving the word very fake names. For example, they are using dialyzer with frequent reuse and very biased in selection. So I don't depend on the hemo study by any way. I only swear that if you have a good science, it's meaning that you have a uremic retention solids, you can find that what is the best for their removal. For your second question, please, you can repeat that.
About cognitive function and uremic toxin.
Yes, I give 1 or 2 slides on this cognitive function improvement, and there is some literature on the cognitive function. Again, hemodiafiltration, there is some go with the improvement, some go without clinical improvement, and basically it depends on the substitution volume. If you are doing good substitution volume, you will have a benefit.
Thank you, Professor, so much. Merry Christmas.
I'd like also to stress on what Professor Hesham said. It's not just uremic toxins. We should consider fluid overload as a uremic toxin. Sodium is a uremic toxin, and this should be considered in dialysis prescription. I think it was clear from this presentation. Do you agree, Professor Hesham?
Yes, and environmental factor. For example, the phosphorus. Phosphorus nature is the monophosphate or diphosphate. And if you change the environment of the pH, for example, metabolic acidosis will aggravate the phosphate toxicity. So it's multifactorial, not only as solids. For example, if you have endotoxemia, high endotoxemia, you amplifying all the uremic toxins. So it's a micro environmental condition, solids, sodium, potassium, bicarbonate, all of them are playing the same game altogether.
So one last question. How can you spread the use of HDF in Egypt?
We are talking about high flux dialysis in Egypt since 15 years. We are calling for that. And the map, it changed now. And the map exactly changed now to more high flux with lower, doctors are still using low flux. For hemodiafiltration, we have to optimize the high flux dialysis first to be universal as prescribed in the guideline. And then we can do for patient hemodiafiltration in a selected way. We have to put around 25% in our scope for patients with hemodiafiltration. Example, patient with comorbidity, intrahepatic hypotension, cardiomyopathy, polyneuropathy, diabetics, we can include first for hemodiafiltration before universal. No country is universal hemodiafiltration for all patients.
Okay. I think you have covered all the aspects of uremic toxins updates and what can we do to remove them and prevent their production. It was a very lovely evening, and I'd like to thank you, to thank Professor Yasser and all the attendants today and all those who shared with us this discussion. And until we meet soon, I wish you all a lovely night.
Thank you very much.
Good night. Assalamu alaikum.
Having a warm night. Thank you very much.
Yeah.
شكرا. السلام عليكم.
شكرا.